Hello.
You left me hanging, dude.
I'm sorry. Been trying. I don't do this often. I was relying on Tara here. Thank you. So good to see you.
Greetings from Croatia, Dubrovnik. How's things in LA?
You Croatia now.
Yeah, I've been here for a week and a half. I'm gonna be here. I'm gonna play hooky for another few weeks.
That's awesome. How's Corona?
She's wonderful. She's actually upstairs with the kids.
Good.
We spent the day on the water. The water's beautiful. I mean, it's beautiful. The waters are 60, 70 feet deep, and you can see it all the way down. The Adriatic is it's a gem, and the people are super nice. And yeah, it's been really wonderful. Anyway,
I
what's
mean,
going on with you, buddy?
not
Well, first
much.
of all, first of all, before we do anything, let me have you introduce yourself.
Yes.
Take it away, Parsa. Let our people, our viewers, know a little bit about yourself and anything you'd like to share with us.
I'm Dr. Parsa Mohebi, a hair transplant surgeon based on Los Angeles, California. Um, we have different offices in Northern and Southern California. And I am a surgeon by training, and I had a fellowship training in hair restoration surgery with Dr. William Rassman. My interests are, you know, hair multiplication, rejuvenation, and aesthetics of hair design and uh, dynamics involved with hair restoration procedures to make it as natural as possible.
Talk a little bit about aesthetics, Parsa. Why don't you elaborate? What's your concepts of aesthetics, and what's been your? I mean, having trained under Bill Rassman, me having trained under Shelley Kabako, we learned under two of the true masters. And actually, we
Yeah.
will talk about the benefits of having going to a surgeon that's trained under someone really legit. But anyway, talk a little bit about aesthetics and talk about how what you learned during your fellowship evolved to what you're doing today.
Good question. Well, hair transplant has obviously evolved in last 10 years, 20 years. At some point when hair transplant started becoming a thing, people just were happy that they're getting hair. They didn't have any hair, now they have some hair. And that was an achievement. And now we're coming a long way from that time. And we are at the time that we can decide exactly what we want, exactly the angles, exactly the type of hair, the orientation of the hair. So there is no excuse not to have a perfectly natural hair in a way that even a hairstylist cannot be able to basically, detect from a normal head of hair. Um,
I love how you say there's no excuse. Never heard it expressed that way, but I completely agree. I mean, I think that's a great attitude, and there is no excuse why a hair transplant is truly not natural looking. Is that, I mean, obviously there are exceptions, and there's always some challenging cases, but why, what is it that, allows us guys like you and I and, some of our other top colleagues to, be able to get such natural looking results?
yeah, exactly. So you asked me about my training and how it has changed since then. I am proud of my training and being trained by one of the pioneers. Bill Rassman is not a stranger to any of us. Um, so he has been in forefront of this field from many years ago, and it never stopped. Still pretty active, still pretty sharp. I was talking to him yesterday, actually. So we're good friends. Uh, Basically, what I learned back then was one of the most important things that I learned was not the surgical techniques that I learned. The fact that he taught me that I should never be happy with status quo. I think that was a big thing, and that still kept going going on. And every day that I wake up, I say, okay, what we could so do differently. And my whole staff has the same attitude. We have this fun thing between the staff members. We have employee of the season, and one of the fastest ways of becoming employee of season is to come up with some sort of innovation, anything that make the system better, make the orientation of the procedure room better, the dynamics better, or the patient comfort better, any improvement. and we constantly make improvement. I'm sure you do the same thing in your offices. This field has been growing so fast. Every year we are having a good 10-15% improvement. I don't know what is your definition of that? How do you see that change in our field?
Yeah, I agree. First of all, I love that attitude, Parsa. I can almost you almost have like a playful look in your eye when you talk that way. And I tend to agree. I mean, if you're not pushing things along and refining it, you're not getting better. And that's part of our whole journey in life, is to try to make ourselves better people, and of course as surgeons to be, provide better outcomes for our patients. Um, I agree that several things have happened over the last year and a half that made my results better. And one of those, minor thing, but I was visited by Jean Devois. I'm a huge fan of the WA system. I don't know if you prefer the Trivellini. I think you're more of a Trivellini guy, or are you a
Really,
WA system? Okay, I'm a WA system. And those are clearly, I mean, I think we can safely say that those are the two top systems for the most
yes.
part. There's the Cole system, and there's the Harris system, and there's the Sanusi Umar, all excellent systems. But I think in general, the WA and the Trivellini are the systems. And I was actually visited by Jean around a year and a half ago. He was coming out with that wireless, which still hasn't been released, the wireless handheld device for drilling. And he says, why aren't you using a brand new punch with every single case? Like, I don't know. He's like, Jeff, that one little thing, starting out every single case, because these punches are autoclavable, and, you don't think of it. And it maybe made things like 2%, or a transection rate maybe 2% lower. What I mean, transection being the hairs not being viable. And since then, our outcomes have gotten even better. And, there's other things. I mean, staying on top of your team, making sure grafts are kept moist. I don't know what else you have, some of the things that you found that have made your results improve, your outcomes better, whether it's the patient experience or your outcomes or your back or whatever else it is that you need to take care of.
Yeah, yeah, a little bit of everything. So I don't know if you probably know. I don't know how you perform your procedures. I haven't had a pleasure of watching your procedures, but I should. Actually, we should visit each other. We see each other in meetings, usually as faculties, but we've never been. I haven't seen your office. I haven't been to your office. I should. Anyways, I do simultaneous extraction and placement. We have been doing it for a couple of years now, and I'm getting very comfortable with it. My team is so basically I pre-made size. I make all the size. The design is done at the beginning of the day, and I'm extracting grafts and placing them. And the fun thing about it is that when we start extracting grafts, we have something called ET40. ET40, like estimated time of the first 40 grafts. That's a very important number. That tells my team that when is it the time that I can give them 40 grafts, because they start with a group of 20 grafts, and 2 technicians should be able to start placing, and they need ET40. I cannot just waste too much time. I have to give them ET40 because they want to start placing. So the time that placement starts and the time of our beginning of extraction are probably like 5 minutes apart. Which is great. So they can place as I'm extracting throughout the whole day. I usually tend to be faster, extractions usually faster. And I have to give myself some break. I have to come to my emails and go back, let them catch up, and then go for another round. So pretty much the time that we stop extracting is shortly followed by the time that placing stops or finishes.
So describe patient positioning. Obviously, you have the patient lying on his or her side to do this, correct?
Yeah. One of the things that a lot of doctors who want to do it, and I've been trying, it's just not possible to have 4 people work on patient's head. I start patients on their face down. So pretty much like face down and a little bit tilted away from me. That gives me that middle of the donor area to start extracting from. So I mark my grids. I mark like 5 grids on the back, like the middle, lateral, more lateral, and the same on the other side. So I start from the middle one and I tilt patient's head and I start extracting from one side. So I'm standing here, patient's head is here face down. Okay, so this is patient's head facing down. This is the back of patient's head. As I'm extracting, my technician follows me. It's called chasing method. So I keep going in one direction away from my technician. And as I'm punching them out, as I'm extracting, she is removing them. And she keeps them in group of 20, put them in graph organizer, the same grouping. If you have to count and sort and even separate singles and twos, that's going to be another step, but sometimes we don't even have to do that. So placers will remove the grafts and start placing in the same group of 20s. And placers are standing here, like on top of patients. And we use loops that are having a longer range. So they can stay
longer focal length.
too close. Yeah, focal point is very far, so they can stay back. So basically the pie of the pizza that they need is much narrower. They don't have to come this close. They have to go back. So we all going back. We're all using our loops, leaving patient's head like far from us. So that makes us be able to work like 5 people at the same time. So the 2 technicians were placing, if airline, they can place at the same time as I'm extracting. And then when I'm extracting the first area, I tilt patient's head to the shoulder. So that helps patients too to not be in the same position for a long time. So patient being on the shoulder allows me to finish this area. And then that's the time that we usually stop extracting before lunch because we want to have everything placed. We serve lunch. After lunch, I start from the other side and go for another probably 30 minutes, 40 minutes of extraction, and that's it.
So I know your ET, you talk about the ET40. What's your ET 1800 graft time? Total start to finish.
Well, that we don't have that ET number because that doesn't have to do only with my extraction. It doesn't matter anymore because
but I mean,
I intend my
yeah.
extraction for them to catch up. ET40, you have to give them 40 to get started, but after that, I'm ahead anyway. So yeah, and since
So
I'm doing,
yeah, go ahead. So if you're doing, I didn't interrupt. Go ahead, Parsa. So if you're what?
doing my intermittent fasting. This is my new thing. Okay, I don't know if you do that kind of stuff. You look so good always.
Been doing that. We've been doing that now for around 4 years.
Oh my God! So that's your secret too. So since I do intermittent fasting, by the time that I start extracting from the first 2 grids or 3 grids, I have probably 1,000, 1,200 grafts, so I can go get my late breakfast. My intermittent fasting is not as good as you probably. I 10 or 11.
No, it's got to be more like around 12:30, 1 o'clock. That's when I'm usually
I'm
eating my lunch.
just pretending that I'm doing intermittent fasting, anyways. So yeah. So you tell me, what are the little secrets that you do? You guys do a lot of stem cell, and we had a very interesting patient together that you referred the patient to me to prepare his recipient area. The gentleman who, very bizarre situation. He got multiple procedure, not much of a good result, and then you propose that you do stem cell and prepare the area, make it more graft friendly, I guess.
Yeah, I mean that's a very small part of my practice. It's an enjoyable part, and I want to go back and talk a little more about our approaches for FUE. But yeah, that was an interesting case. And did you wind up doing his transplant? Because I know he
I
had
did.
several procedures. For one region on the right front, I think it was the right frontal temporal section area, just had low regrowth, or he lost some of the hairs. So the only thing I could think of is there was a compromise in his blood supply. So we decided to. We did an autologous fat transfer, basically took a little bit of liposuction, which wasn't easy on him because he was a muscle builder. I think if I remember, he didn't have a lot of fat, but all we need is around 40 cc's. Purified the fat, filtered it, combined it with PRP, injected it into his recipient area, particularly on that right side, but throughout the whole frontal region. According to the technique, actually, Garana developed the technique. And then 3 months later, that's the prescribed time for doing a transplant. Concept is fat not only has stem cells, but also, and you don't need to break down the fat with either chemically or mechanically. It's just the fat in and of itself has the stem cells. But other advantages of fat is you get neovascularization. You get softening of the tissue, and you get, actually fat has anti-androgen effects too. I don't know, did you wind up doing his transplant?
I think I did the procedure. I've seen him a few times, so I think the procedure was done already. But procedure was not anything, unusual for us. So if I'm not clearly remember if I did it or not, I think we did it.
Yeah, I
But
think so
we've
too.
meetings before to just see him, and I remember that he mentioned that even he saw some improvement after your fat transplant, and he said
Cool.
that he was pleased, and yeah, that was interesting. So I think a lot of those procedures we may have in the future that they're not quite clear to us yet, but with this little experiments, we can probably have more insight and then hopefully lead to bigger studies to see what works and what doesn't.
Yeah, and it's also great that, here we are bi-coastal and we can share patients, and
Exactly.
it's a nice opportunity for us to work together. So what are we doing with FUE? I mean, I guess our focus, probably 70% of our patients is a shave FUE. But we also offer a partial shave, minimal shave, and a no shave. So we offer
Mm-hmm.
4 levels, and I'll have you tell me about that. But obviously, a no shave, which is where we're literally not trimming any of the hairs in the back other than those that we are removing. So it's not a long hair FUE that's been described with certain kind of special punches. We actually are trimming each individual follicular unit. So it's a 2-stage process. We first trim the follicular units, then they get removed. So it's definitely a more time-consuming process, but we're able to do, well, from the back, we're usually harvesting. The average patient is probably 1,500 to 1,800 grafts from the back. So our approach, Parsa, is to get as many of the grafts. It's a 2-person system. 2 people are harvesting the grafts from the back. Usually that takes around 2.5 hours. We have our 1,500, 1,600 grafts. Meanwhile, we have 2 assistants. They are going to be most commonly the ones that load the implanters, the dull implanters. So it's because we use a 4-person planting system. So they're going ahead and they're dividing the grafts. If, for example, in cases of beard restoration or hairline work, they're doing trimming. We're seeing, we're making sure the grafts are properly dissected down as needed. We then flip the patient over, numb them up, inject PRP into the scalp. And by the way, one of the things we just started doing is we offer Pronox. So in addition to oral sedation and the occasional patient choosing twilight sedation, we just added Pronox, which is basically nitrous oxide laughing gas, and our patients really like it. So it's something you may want to offer. They can, I don't know if you offered already, but.
For years now.
Oh,
Yeah.
okay.
It's stopped
It's
doing
great.
injection many years ago. It's really good.
Yeah, so I'm glad to hear that someone like
And
yourself is doing it and have been happy with it.
anything, just give the tube to patient. Patients are in charge, basically.
Yeah. Yeah. And so anyway, and then we start the planting process, 4-person system. After I make the recipient sites, and of course we size them based on the size of the grafts and the elasticity of the scalp. And then we start the planting process. And usually the grafts, the first 1,500-1,600 grafts typically take around 2 to 3 hours to plant. Then as we need more grafts, we start doing harvesting from one side while we continue doing the planting and making more recipient sites.
Also do a little bit of a simultaneous extraction placement. So you don't remove everything and place them all.
Correct.
And then place them. So the grafts won't stay out for a long time. That's great.
That's the big advantage, right? This way the grafts that we're planting at 3 o'clock in the afternoon were not harvested at 8 o'clock in the morning. They were harvested at 2 o'clock.
Exactly.
Boy,
So
great minds think alike.
this concern about these grafts, from the strip time, I've been concerned with the grafts sitting out for such a long time. And even back then with strip, I didn't remove the entire strip. I removed half of the strip and the other half after lunch, which was cutting the time half at least. So it's good to be cautious about these little details. I see that you're doing pretty much the same thing.
Don't do a lot of strips anymore, but maybe 5-10% of my work, mostly on women. But yeah, you're of that mindset as well. FUE is the way to go, right?
Yeah, absolutely.
So what do you do? I mean, you and I both see patients that are coming to us for second opinions, or they're getting we're third or fourth opinions, and they're saying, "Oh, doctor told me FUT is the way to go." Obviously, if they're under 35, 40, you're probably going to say no way. But how about those other group of guys, and how do you address those inquiries?
I feel like I've been there. I've been one of those doctors who was promoting a strip for a long time before I got comfortable with FUE. And in fact, it's not about our comfort. FUE is getting better. It's not just we are doing it better. It's just getting a better procedure. So 10, 15 years ago, FUE was not what we do today. The punching was different. The transaction rate was significantly more than what we see today. The size of grafts were different. The size of punches were different. We couldn't even imagine using like 0.8, 0.9 millimeter punches. So back then, obviously, I'm sure you've done a lot of these that try to, you know, convince patients to do a strip procedure as opposed to FUE. I was doing like FUE only if they twist my arm. I don't want to do it because I could see the differences, the result is different. But then when we kind of get the new concept of FUE, we learn how to do FUE, we felt okay, grafts could be harvested, perfect grafts either way. So FUE is not a problem. FUE is a solution because sometimes some areas that a strip cannot even touch, FUE can remove hair from. We can remove hair from anywhere. We can do beard hair transplant, body hair transplant. Not a problem. And the smallest size punches, there's no scarring, there's no even hypopigmentation in most cases. There's nothing to be seen. So it's a no-brainer. I mean, there's no reason to do a strip. I mean, at this point, I really feel like a strip, as you said, they're limited to very few cases that a strip may do similar or maybe better, but most cases you can get by without a strip without any problem. But again, when patients are coming to me, the funny thing is when patients are coming to me and say, this doctor said the strip is better because of this and that, and you have more grafts, you can grab more grafts and stuff. I said, you know what? That doctor's very honest, probably, because he is saying based on what he's seen, he is getting that kind of result. And I was there just a couple of years ago. And I don't think that's anybody's fault. It's just a matter of time that people get used to it and get comfortable with it until they can offer it to everyone.
Once again, you spoke. I agree. That's the second great quote I've gotten from you so far. The first one when you said there's no excuse for not being able to create naturalness, and the second thing is it's not just that each of us are getting better. The whole field in terms of FUE is getting better as well.
Yeah, yeah. So how is your reaction to those situations when you see a patient is coming in, putting you in front of your colleague that, hey, they said the strip is better. What do you say?
Uh, uh, you know what I tell a patient is, listen, I'm only going to do the best that always going to tell you what I think is best based on my experience. So whether it's someone coming to me saying, well, I heard the robot is wonderful, or strip is what I say, you know what, there is a role for these procedures. Well, not necessarily the robot, but there's a role for FUT strip. I just don't think it warrants in nearly all cases to do additional grafts. And the biggest argument is the two big arguments are that the regrowth rates are better with strip than FUE. Not true anymore. I mean, that's been shown. Ron Shapiro and David Josephides, our colleagues, did a study. They, I mean, clearly showed that the regrowth rates with FUE are as good, if not better. And that's, I'm sure, your experience as well as my practice's experience. Secondly, when you're doing FUE, the number of hairs per graft, at least with the first pass, is higher than with strip. Because when you do a strip, we're not, as opposed to FUE, where we're selecting out mostly the larger grafts, which is usually what you want, particularly in that first procedure to restore good density up front, except for that area along the hairline. You know, so we're getting a greater number of hairs. So higher rates, as good, if not higher rates of regrowth. because there's less extra or out of graft or out of body time, ex vivo time. There's less manipulation. You're not cutting under a microscope. You're just removing the follicular units with the FUE. And then, of course, the other argument is the total number of grafts are greater with strip as opposed to FUE. And my response, and you alluded to that already, is, well, I can compensate for that by taking grafts from the beard.
Yeah, no,
And
that's
you're not
that's
gonna have a scar. Like, why put a
yeah.
scar in? Why put a scar on you?
We have seen so many bad scars that we have been waking up so many nights because of strip and throbbing pain and everything like that. It's just like it's like day and night. Is I hope the people who are just doing a strip now, they consider just retraining the whole, going through the whole thing and learning it again. Uh, just denying the fact that if you is getting better, it's not a solution. It's not serving our patients well. Um, I sometimes see some of my older patients that I give them a strip, and you know it's out of our hand. You know, scar healing is part of it is the technique. A good portion of it is patients' healing potentials. Has nothing to do with us. And one person with the same technique, scar is invisible. Another one, like half centimeter white scars. There's nothing to do about it. And now I see them, I do FUE, repair them and everything. I usually give them even extra grafts because I feel I'm responsible for those scars. So yeah, but no more scars. That's beautiful, and no more tightness. Occasionally, pay people for days. They have pain, throbbing pain, and everything. None of those. And people who had those procedures and now they're getting a FUE, they're shocked how, you know,
Easy.
smooth. Yeah.
Yeah.
And now, as you
So
said, hair transplant, things are going to be even easier, less disruption to people's lives. Tell me about
yeah,
your long hair. How many of those do you do?
we don't do the long hair. We're just doing
No, no,
you know,
I meant not.
oh, the no shave.
Yeah.
I'd say we probably do. I would say probably 15 to 20% of FUE cases are no shaves. Usually, it's guys that want to go back. You know, they tend to be a little more discriminating. Um, you know, professional athlete or professional sport coaches, prominent business people, people in the public eye, or just, you know, guys that just are willing to spend the extra money and want to get that, have no, you know, no telltale signs. We don't normally shave the recipient area. I assume that's the same with you, or do you routinely
No,
shave the
I
recipient area?
patients I like to shave. I feel a little bit more comfortable when I shave. I think that it may affect my precision. Um, a little bit, not that much. I mean, if patients say no, we say that's fine. We just do partial shaving the back. But if I
Yeah,
can't shave, like to shave, makes the whole, especially with simultaneous extraction and placement, it makes the whole thing go more uh, smoother because it's just a little bit complicated to start with. When four people work on the patient's head, you add
yeah,
to it like hair, which makes it a little bit harder for the placers, especially to place.
sure.
Um, But I think that no non-shaven is becoming more popular. And then, as you said, if the price difference was not, I guess more and more people chose non-shaven.
Yeah, because we're limited to usually no more than 2,000 to 2,200 no shave grafts in a single day.
Oh, you do
Um,
200.
what's that?
You do up to 2,200 per day?
Yeah, it used to be 15, 1,600 in a day, but it's now up to, you know, 21, 2,200 usually. And for most patients, that's really all we need to do. If they want to come back the next day, we can, you know, we'll usually do all the harvesting from the back and maybe one side. And if we want to go more than 2,200 because either they have a really good donor supply and or they have the need for those additional grafts and they're motivated to have those, we'll bring them back the next day. They'll come in at 8 o'clock, you know, 7 o'clock in the morning. We'll have them done by 10:30, 11 o'clock, and they can fly home that evening if they, you know, that later that same day.
What is the biggest size shaven FUE that you do?
Biggest size, not biggest
Shaved FUE, like normal FUE.
in one case. I mean, how many will we do?
One day.
Or I mean, we've done as many as 4,000 grafts in a single day, but that's the
Wow.
exception, Parsa. We will typically, most of our cases are, 1,800, 2,000 grafts, up to 26 to 2,800 grafts. Sometimes we're combining them with beard. If we're going to do more than around 800 to 1,000 beard, along with more than 1,500 to 2,000 scalp. That's about, I mean, not scalp, I'm sorry. Yeah, we can't usually do more than like 2,800 grafts total,
Mm-hmm.
beard, scalp in one day in the best circumstances. We'll
Yeah,
try.
good number.
I mean, I just don't like to work anymore. I mean, I don't like my team to work past 5:30. We start early in
Yeah.
the morning. We'll start, our first case starts at 6:30, have a patient
Oh,
start at
wow.
6:30 so we can, yeah.
Oh my God, I have to tell my technicians a little bit extra hour of sleep.
What time do you guys usually start?
30. I mean, I sometimes start at 8. We have another doctor. He starts at 7:30. I start at 8.
Okay. Yeah, I
Yeah.
like starting early. I find that if we can get, 60% of the case done by lunchtime, we start, it also helps with your intermittent fasting, by the way. Because listen, you're starting at 6:30, next thing you know,
Everything
it's
works.
11:30, 12 o'clock, and you're cranking, and that's when you take your lunch break. But yeah, I like to, I just like to get going early. And especially since we're doing more than, one or two cases a day. So we like to, I assign the people, my team in different rooms, and that's how we like to do it. This way I'm usually out of the office. I'm usually done in most days by 5:30.
Okay,
So I
good.
can be home by, 6:15, so I can, hang out with the family a little bit.
Good kids.
How are your kids, by the way?
They're doing good. My son is going to college in a couple of weeks, actually. My daughter is 14. So they're good. They're still enjoying summer.
And what's your future plans with your practice?
Well, we are, I don't know, we gradually have been expanding. We have like two physicians here, one in San Francisco. I'm thinking of another one maybe. I'm not sure how soon I want to do it. The demand is there. Kind of people are pushing us, patients are pushing us. Like a lot of changes we do in our practice because of, the demand, as it should be. So yeah, that's pretty much it. We're working on another generation of implanter. We're working with engineers and designers, and yeah, that will be a little bit more automated. Um, I'm very hopeful that will cut down on the placing time. That is the biggest. I mean, the time of procedure we have, our time of procedure with simultaneous extraction placement is limited by time of placement because
Hmm.
extraction is always faster. So if you can cut down that placing time, automatically we can finish the procedure earlier. So we'll see. We're going back and forth with the prototype and different things. So
Start
a lot of
start at 7 a.m. You'll get another hour and a half of planting.
that's a good idea. So they can make sure that it's not staying behind my emails at least.
So we're both surgeons. What's the difference between surgeons that do this procedure? And obviously, we're not claiming just because we're surgeons we're better at doing surgery, because there's many outstanding, um, outstanding hair restoration surgeons who, do not have surgical background. But where do you think your surgical training comes in, and how does it impact your practice?
I don't know. I mean, surgeons are better with their manual technique and hand-eye coordination to start with. That gives them an advantage. And then we wanted to become a surgeon. We like to do things with hand. We have a we have a selection bias right there
Hmm.
because we were pushed to this field because we have to do it now. I've seen it in some other specialties that they just, they do it because, yeah, they make money, they have to do it, procedure, but they not necessarily love to do surgeries. But I personally enjoy doing surgeries. When I go to vacation more than a few days, I miss my procedure room. I like to do this thing. So that's how I am. Although, as you said, there's some good dermatologists who do good hair transplant. One of my doctors here, he's a dermatologist. We have good conversations. He usually, jumps on the science of skin and hair, and then I get it from the other side, and we always come up with a very good conclusion. Yeah, I don't know. I mean, obviously we are biased, but people from different on both sides of aisle could do well in this field.
By the way, someone asked where you're located. Dr. Mohebi is located in Southern California in LA. How long have you been in practice, Parsa?
I started in the year 2008.
Okay.
That's where fellowship and started my practice. So it's like, wow, 14 years already. How about
I
you?
got
How
you.
long
I
of
got you
hair?
beat, man. 94. I did my
Wow.
fellowship in 93, joined, and I started my practice in 94.
Oh my
And,
God. 94.
yeah.
Wait, you look younger than me. What's the secret?
Um,
Finished my
Cro-
medical school in 94. Let me see. Yeah.
Croatia, man. Croatia and Serbian women, or
There we
woman.
go. There we go. Good. Credit to your wife.
You should
That's
see my
all.
mom. My mom, who's here with me, she's 84, 80 plus, and she's a rock. Just lucky, some lucky genes there.
Yeah.
Um, so one of the questions we were asked is, and one of the topics is, how do you pick out a good hair restoration surgeon? And what better way than to ask you personally, not that you've had a hair transplant, but you had to pick an associate. You had to had someone join your practice. So what were those characteristics that led you to feel that this person, besides personality and obviously ethics and maybe a sense of humor or whatever it is, but how did you choose your colleague? And then let's talk about from the more generalized question, how does a patient out there choose a top hair restoration surgeon to be assured of getting the best possible result?
I'm not sure it's the same if I choose a doctor for my practice to join the practice or patient. There might, I mean, there's some similarities. Like I want them to be passionate. Passion is very important. I mean, I interview people. I mean, I have a fellowship training program, and I've done it a few times. So some of these people they're just looking at it as a job, uh, or they're just tired of existing job and they want to do something new. That's not a good reason to go to this field. Uh, People that I like, that I, you know, invited to join my practice are usually very passionate. They're passionate about it. They're comfortable with change. They like to improve. They they're good with people. They're passionate about helping people. That's probably the most important thing. And then when you have the passion, everything else comes with it. So you have to uh, keep yourself on top of the game. You have to keep yourself educated. You have to use the best skills. You have to update your skills. Never stop improving, because everything is for your patients and for the outcome you want to get. I think that's probably the most important thing. But I mean, I have my own methods of doing the hand-eye coordination when I bring the doctors on. Obviously, that's very important. Some people never get it. Some people just don't have it. Not that they cannot learn it, but it's just very difficult. It's a struggle. But if they have it, we do everything under microscope these days, right? So like this tactic vision and having 3D vision and comfortable doing things microscopically makes a difference. Uh, yeah. Well, how about you? What's your approach to this? Hiring
Well,
another doctor?
I think that, or just on a side note, that manual dexterity test, we actually did it for all 18 of my assistants in the office. And I wanted to see how much it correlated with their skills, their hand-eye coordination correlated with their responsibilities in my office. And my two top planters, interestingly, both had the highest scores, but which is fascinating. And we also identified one of the younger people that has joined us just in the last 4 or 5 months. She was like the third highest score, never did anything other than prepare grafts because she'd only been with us a couple of months. But she's already, now this was already 4 months ago, so that's she's been with me 7 months, and she's already showing signs of being an outstanding planter. I think that, but let's go back to, passion. And clearly, I too see people that, are doing, just doing it. Basically, it's like, well, or want to add it to like their current practice offerings. I'm not here to say that's wrong. I mean, I understand, doctors want to provide as many services as they can, do as much for their patients as they can. It may not be just self-serving. It may be that they truly feel that they can do a good job. And I think some of these doctors, particularly those that use these per diem techs, sort of drink from the Kool-Aid, and they think that, oh, these techs did so-and-so, the football player, or, so they're really good, and I would have them do my procedure. But we know that it's more than that. So it's not just a technician-driven procedure. Obviously, that's why guys like you and I see eye to eye, and we can, we share that passion. For us, it's not just, oh, it's something I'm doing on the side. I think that one of the things you talked about, I think personality-wise is really important. I think my patients bond with me. They like me. But at the same time, I'm not, with the exception of, I try to maintain a doctor-patient relationship with all of them. Although getting friendly, I think, though, that some of our colleagues tend to be very buddy-buddy with all their patients. And I don't necessarily think that that's a good or a bad thing. I just tend to want to maintain, I don't know how to say this. I guess when I'm in surgery, I like to be as professional as possible. And I like to really be able to think of that patient not as, anything other than someone who I'm going to just try to my very best on. And, it transcends being friendly with people.
Yeah, you don't want to be best friend with your patients. That brings another layer of complexity. You want to be professional, do your job, be respectful, and like your patients. You like, obviously, and you have their best interests in mind. But I know what you're saying. And the funny thing is, patients don't like it too. I've had patients that's coming from another doctor that's like joking around and doing this. And it's like, it was not a doctor. It was like a clown. Okay.
Although I do tell some good jokes. I always like to tell jokes, but
Good jokes are good. I'm not good at telling jokes, so I'm sure you're much better than me.
Okay, I got a good one for you.
Okay, tell me.
These two guys are out hunting, and one guy accidentally shoots his friend. This actually won the award, the Joke of the Year award, given out. It was like 5 or 6 years ago. Anyway, the guy shoots his friend. What does he do? He calls 911. Calls 911 and says, "Operator, you got to help me. I think my friend's dead. I shot him accidentally." And the operator goes, "Well, please first, make sure he's dead." He goes, "Hang on a second." I'll see you. Goes, "Yeah, he's dead."
Oh my God.
Anyway, that's a good one. You can tell
That
your
was
patients that one. That's always a good one. And then I got here's a doctor one. This old man goes to this old man goes to the office with his wife, his elderly wife, and the doctor goes, "I'm going to listen to your heart." The old man goes, "What?" Wife goes, "Pull up your shirt. He's going to listen to your heart." Okay. Then the doctor goes, "I'm going to take your blood pressure." And the old man goes, "What?" He goes, "Roll up your sleeve. He's going to take your blood pressure." And then the doctor goes, "I'm going to need a urine and a stool specimen." The old man goes, "What?" And the wife goes, "He wants your underwear." He wants your underwear. Sorry, that's my doctor joke.
So the problem
Um,
is don't remember the good jokes. Patients sometimes tell jokes in procedures. I have to remember it. I have to tell kids this. I go home. It was a good joke that I cannot remember now.
there you go. So that's one. So okay, since we got just around less than 10 minutes to go. So what do you tell the people out there? How do they choose their surgeon? What are the things that, how do they find a Parsa Mohebi? How do they find, another top doctor, myself and other of us colleagues? We know who the good guys are. Like I
Hmm.
literally will say to my patients, listen, there's there's maybe 6 or 8 guys that I would 100% tell you to go to. They don't know
Right.
this.
Yeah.
And I feel bad for them. I mean, they don't know who to believe. So
And it's
what do you tell?
hard with the internet. You they can present themselves in any way they want, and some good doctors they don't have time for it, and they're not getting the same share of the exposure. Yeah, I mean, if I were a patient, if I want to tell a patient where to go, I start with, I mean, the first thing, I mean, we cannot undermine the value of bonding with your doctor. That's, you have to see the doctor, you have to bond with them, you have to trust them, you have to, I mean, there are certain things that we subconsciously get from any conversation. People are smarter than what we think they are. People see the truth. You cannot play roles, you cannot pretend something that you're not. So good or bad, they can see it more than what we think they do. Uh, that's a great thing. So they have to trust the gut feeling. They have to see the doctor, talk to them. Don't just base it on what they see online, because those could be, you know, adjusted and changed and glorified. But other than that, the years of experience, the methods of procedure they do, they have to educate themselves first to see what's out there and what's the best way of doing things, and then figure out what the doctor has to offer, it can offer, and then education, relevant education, where they're coming from, how many years of dedicated education they have to this field. And then if they want to go deeper, their involvement, again, the passion of doing what they do can show itself through their, conferences, lectures, articles, publications, research projects they've done. And there's a few organizations that they have the screening methods. They're not 100% perfect, but I mean, they can give patients some peace of mind that this doctor has done this and that. They have certain things matched to be able to get those certificates. Um, so that's what I feel.
Yeah,
What do you?
it's tough. Yeah, it's a really tough question because I mean, you didn't mention this. I mean, you really got to look very critically at the doctor's portfolio of results.
Mhm.
And I think that one thing that's been really valuable for me has been making videos. I have a lot of videos. Many of them are not showing the patient's faces.
The top, yes. Results, you have to see them, many of them.
Yep. And, ask the doctor what he or she specializes, what he or she specializes. For example, I mean, I think that clearly guys like you and I mean, we're not, I mean, even though we do strip, it's not, if you really want strip, I mean, I'm not saying we shouldn't go to us, but I mean, ultimately it really comes down to the artistry and having a devoted you want a devoted team of assistants. I'm sure you agree with me there.
Yeah,
You want a doctor
absolutely.
that his assistants are there working full time. I mean, I've been seeing who's been joining this, this Instagram live, and I'm seeing several of my people from my office because they're passionate. They want to learn, but also they feel like they're part of the family. I mean, it is. I'm sure you have a very similar environment. You started out, you'd have that award of the clinic, the employee or the team member of the season. I thank every one of them almost every day as I leave the office because they're such an essential part of my practice.
They
But
are.
anyway, I think number one, credentials are important. In fact, someone asked, is it all right to ask for a doctor's credentials? Absolutely. I mean, these are all things. that you need to be doing homework. I think it's I think it's 4 or 5 key things: seeing the before and after results, making sure they really specialize in this procedure and they have a team that it's devoted to them, because the team members are so important. The personality, the professionalism, that feeling that the office is going to be run the way you feel that you're going to have complete confidence. Because I do think that there's a role when patients have a bad experience and or come in with a negative mindset. It's no surprise that those are the patients that not infrequently are going to have the most healing issues. I don't know if that's
True.
something you've observed. It is, right? It's like you basically say, you roll your hands up, your eyes up in the air, or you throw your hands up in the air and say, I would have predicted this patient was going to be a problem because he was so negative to start with. So, talk to the doctor, whether it's a webcam, whether it's, meeting in person. Listen to those those video testimonials. I think you have to hold testimonials, or what do you call it, reviews, online reviews. I think overall they can give you a nice approach. But listen, if a doctor's done, I mean, I've done 19,000 hair procedures. I ain't going to have 19,000 positive reviews. I don't have 19,000 reviews at all. But, in general, it's all right to have a few, I wish it could have been better. And you and I
Yeah.
know that there are some cases that we did 3 years ago that we did it today, we probably would have done something just a little bit different, because we've learned and we're always getting better.
Right.
Thoughts?
Right. Yeah. Yeah. No, that's true. I mean, reviews could be like falsified, and having bad reviews are not necessarily equivalent of not doing a good job. People have different expectations. I mean, we had reviews that gives us like 1 star because we charge consultation fee. So the
Right?
person didn't, yes, bother to come to the office to charge consultation fee. Why should I go? It's okay. I mean, people can read through them. People can read through those words and find out the reality. But one important thing that I forgot to mention was that result that obviously is on the very top of the list. And not only the online results, you can even go and see some patients. I mean, we do have, I'm sure you have it too, some patient models that are willing to share their experience or their
Of course.
results. Go touch them and feel them. And I used to do open houses. We don't do them anymore. It's just too much of a hassle. But that's a good thing. I may bring them back again.
Hmm.
So Dr. Rassman always did open houses very religiously. So people can get more comfortable. Uh, yeah, seeing the result, there's nothing better than that. And talking to someone in person. I mean, I don't know how your practice is. I'm sure you don't do as much marketing after all these years. You probably don't have to, because word of mouth is the biggest thing. And most of the patients who come to my office and they want to do procedure with me, they already sold. The funny thing is, because we have a waiting time, they go book their procedure because they know they cannot even wait a couple more weeks or months to see me. So they secure that, and then they come and see me. This is a good thing, and they come from another doctor, another patient, another somebody who had a procedure, and they know they want it. That's not a question. The question is, okay, what needs to be done? Okay, do the measurements, do whatever you need. Just put me in schedule.
Yeah.
So it's
Yeah.
beautiful. I mean, our new doctors, obviously, we do marketing, but when you're in practice and do a very good job, usually most of the patients are coming word of mouth, and
I'm
that's
really,
beautiful.
I'm really happy, like a guy like you. I mean, it sounds like it's been a pleasure talking to you, Parson. I'm really glad you're doing well, and it sounds like you got your shit together, dude. You know, really, it's nice. So, what else you gonna do? What else do you do when you're not in surgery? I know you've done some traveling, and what are some of the things you like to do personally?
I surf. I work on my surfing. So we're in Los,
Nice,
we have good waves, and I at least try to go once a week, be in the water, just spend a few hours. We also have hiking, good trails around here. I have a like mountain house. I go there, like spend some time, go around mountain biking, a lot of outdoor activities here, and
nice.
spending as much as we can.
Wonderful. And what are your
Yeah.
plans? What are your future plans with practice and your life, and just any big things coming up?
I mean, I'm trying to, I think my future of the practice will be mostly focused on technology. We're just improving these little things here and there and coming up with new gadgets that not only help our patients, it could help anybody's patients. But I see gradual just expansion, probably more doctors joining the team. Um, how you see your practice? You tell me. You have more experience than I do.
I still love what I do. I am definitely cutting back. I still, when on the days I work hard, but I also, I take more time off for myself, which is, I think has made a tremendous difference in my interactions with my patients.
Mm.
I think they recognize that I'm just more present. There was a while, probably around 10 years ago, where, just through a combination of factors, I just was working, and it was wonderful. And I needed to do that at that time, but I'm able to cut back. Plus, I completely dropped pretty much all facial plastic surgery. So I'm just doing hair.
Oh,
Um,
really? That's
yeah,
good.
I dropped my rhinoplasty practice around 2 years ago. My partner, Tony Barrett, has been with me now for a little over 10 years, and I just saw the work he was doing, and I loved rhinoplasty, but I loved it, and I had happy patients overall, but it wasn't what I was doing the best at. Plus, when you're doing a rhinoplasty, you're stuck in that operating room for 3 hours or 2.5 hours. So it's taking away my ability to do the hair the way I wanted to, and be able to sit down with my patients during consults. And that
Mm.
made a huge difference. And I tell all younger doctors that are sort of deciding whether to limit their practice, I think there's tremendous value in specializing in just one thing. So basically I gave up all my facial plastics, um, and to devote myself fully to hair. I mean, it made my team happier. It made just about everyone in my office happier, and because everything just makes more sense, and it's more, it just is a better experience, and it starts with me, and it parlays
That,
with my patients.
yeah, just doing as much as you can is not usually the answer. Do as much as you are doing it with full potentials and full energy.
And
And how many
the other thing
make
is
you feel?
I changed my I dropped my New York practice. Right, actually, it was going to happen anyway, but right around when COVID started, I said that's it. I'm done going to New York. Now, mind you, I didn't have a colleague there. I did have a young associate there who I trained and who still has a hair practice, but I just walked away from it. Unlike you, who's, you're really devoting yourself to